All right. Well, I know it's 1 minute past the hour. I think we could go ahead and get started. Welcome again, everyone. Thank you for joining us. Good afternoon or good morning, wherever you're calling in from. My name is Samira Mackey. I'm the project manager on the Moving Forward Coalition. And our director, Isaac Longobardi, and chair Alice Bonner are also joining us from the Moving Forward Coalition team. As I mentioned, we'd love to see who's joined us today. If you haven't already, feel free to chat in your name, your role, and where you're calling in from today. And thank you again for joining today's webinar on the action plan about the nursing home health information technology guide. And on today's call, I will be briefly talking about the coalition before I pass it off to Cynthia Morton, who will be sharing about the coalition's action plan to create an interactive guide that we are hoping will help nursing home operators navigate new regulations and evolving data and payment requirements. And then we'll have some time after Cynthia's presentation for questions. So please chat in your questions throughout the call or hold on to them if you'd prefer to come off mute and share them verbally. And then we'll be wrapping up with ways you could stay connected to the coalition at the end. So before we get into it, we would like to, I hear a little bit of an echo, but it sounds like it went away. We'd like to thank the John A. Hartford Foundation for funding the Moving Forward Coalition. Thank you for allowing this work to happen. We're really excited about what we've already accomplished already in year 2, and it's only been a few months. And I'm looking forward to all the good work that's underway. So for those who may not know, the Moving Forward Coalition is a diverse group of individuals and organizations who have come together, committed to drive specific, actionable improvement in nursing home quality. And we've engaged over 1,300 individuals, including residents, CNAs, other nursing home providers, advocates, QI and QIOs from really across the country. And I know those are many of you on this call, and with all of you, we've built our vision in which every nursing home will be a community in which lives are nurtured, residents are empowered, and where people want to work. And in the past year, we took this report from the National Academies of Sciences, Engineering, and Medicine, or NASEM, that detailed holistic approaches to improving nursing home quality. And we prioritized 7 areas that could be translated into actionable steps in the now. And really over the past year, across many, many committee meetings and discussions, we were able to develop these 9 action plans that we published on our website in July. And each of these action plans outlines a particular challenge facing nursing homes today and defines a step-by-step plan to achieve them over the coming year. And in today's call, we'll be learning more about the action plan on the HIT, or Health Information Technology Readiness Guide. And I'll chat that in if you want to follow along. And with that, I will pass it over to you, Cynthia.
Thank you, Samari. Maybe forward the slides just a little. There we go. So to reintroduce myself, I put my introduction in the in the chat. I'm Cynthia Morton, and I'm the executive director of an organization called Advion. Our old name was National Association for the Support of Long-Term Care. Many of you may have known us as NASL, and we are an advocacy organization for ancillary services in the long-term post-acute care continuum, mostly companies like information technology companies that are producing electronic health record, electronic medical record, or therapy companies. And it's been really exciting to join the HIT group. And I want to give a shout out to, I see in the chat that some of the members of our HIT group are on the call today. I see Maria Moen and Dan Scholik, and maybe there's a couple more. I don't want to miss anybody. Those are just the first names I saw. If you'll advance the slide. So it was really exciting to see in the NASEM report an HIT recommendation, an information technology recommendation. The way I like to explain it is that we have not had such a recommendation from such a respected high-level group of people that are issuing recommendations to reform nursing homes. We see lots of recommendations to reform nursing homes over the year, maybe not as august as the NASM report, but to include information technology was really, really remarkable. We don't see this, and it's something to definitely jump on. So there was a recommendation and a goal in the NASM report. And just to kind of highlight here, the report mentioned that the use of HIT has the capacity to improve the quality of healthcare for nursing home residents while improving the productivity of staff. But we've got a long way to go, and the report very significantly recognized that more effort is needed to facilitate the adoption of HIT in nursing homes. That we're not nearly there yet, and we've got a long way to go. Next slide. The HIT portion of the report, that the group, and we have several of the people who were on the original NASM group in our HIT group now working on trying to make this a reality. The guiding recommendation from the report that we're working for is just a wonderful recommendation, and I'm going to read it to you. It's right there on the slide. The ONC and CMS should identify a pathway to provide financial incentives to nursing homes for certified electronic health record adoption. Should identify a pathway to provide financial incentives. These words, pathway and financial incentives, are very, very important. I'm going to kind of come back to them in just a second. Next slide. So as our HIT group got organized, as we organized ourselves, we organized into two groups. We have a short-term priority, and then we have a longer-term priority. And the short-term priority, which I'm not going to go into as much detail here on this call, was all about using HIT to gather residents' goals, preferences, and priorities. Develop a description of these, and develop and test a process to collect data that relies on individual resident and their caregivers, thereby reducing the total data collection burden on staff. And that is moving along quite well. For those of us that organized into a long-term priority, and that's the one I'm going to detail a little bit more here for you, and I welcome feedback and comments from everyone on the call today. We are establishing a roadmap for the adoption of HIT, but it's HIT that is going to be required for success under value-based payment models that are going to be really needed by nursing homes by 2030. And I'm going to go into that in a little more here for just a second. We also organized to identify specific HIT-enabled tools and test a phased implementation. And then there's a nice link there if you want to go into a little more detail on both of those. Next slide. So to provide you a little bit of context about where we're kind of coming from, both from the recommendation in the NASM report, as well as kind of our detailed plans here on our two work groups. Many of you know, probably all of you know on the call, that nursing homes really lag behind other sectors in terms of EHR adoption and just our overall HIT maturity. Only about 84% of nursing homes have adopted health information technology, and about 60% lack the ability to share data with other providers. That particular piece is really key to what we're doing in this long-term group. So we know that's where we are, and a lot of this stems from a lot of kind of issues we've had with lack of HIT maturity, which I'm going to talk about in just a second. But we kind of balanced where we are now in terms of HIT maturity and our lack of ability to exchange data, our lack of adoption of electronic health record. We balance that with the context of a goal that CMS released, I think it was last year, where CMS said they are committed to transitioning all original Medicare and other Medicare beneficiaries, most of Medicaid if they can, to value-based care arrangements by 2030. And that goal of CMS's is really kind of been our guiding light here in terms of this work group. For nursing homes to keep up with this goal, to be ready for this goal of CMS's, is really going to require significant EHR data collection, and it's going to require interoperability among nursing facilities. Next slide. As I mentioned just a second, there are a lot of challenges, and these challenges probably are not strange, not unknown to those of you on the call, but I think it's important for me to kind of point them out because this is reality. This is what we're dealing with. We've had lack of incentives. I keep saying this, but I'm sure many of you know that many years ago, Congress incentivized hospitals and physicians. It was the HITECH Act. And they put out, I think it was $35 billion out there for those sectors to link on to electronic health record. But the long-term post-acute care sector was left out, and behavioral health as well. We were left out of those incentives. So we've been kind of limping along, trying to connect, trying to mature ourselves in terms of HIT all along without any money infused into our sector to help us do that. That has probably been one of our most significant barriers. We also have lack of data standards, inconsistent use of HIT. Some providers are able to spend more money and really kind of bulk themselves up and get ready and adopt HIT. Other providers have not been able to make it a priority for various reasons. Not a lot of understanding of interoperability out there. And I always like to level set. Interoperability just simply means the ingestion and the internalizing and the sharing. So data movement back and forth between you and a partner, where you can share data with that partner and you can receive data from them and ingest it into your system and use it. That is kind of a layman's version of the definition of interoperability. I also think workforce readiness is another issue, specifically in our nursing home world. Not all of our clinicians are ready or maybe willing or open for data sharing, for moving into this new world of trying to read an electronic health record or kind of incorporate it into their work plan. That is definitely an area in transition for us. Next slide, specifically in nursing home world. So a little bit more about this goal, especially if it's new to you. So again, CMS has a goal of all original Medicare and most Medicaid bennies will be covered under an accountable care or a value-based care arrangement by 2030. So they're not, you notice they don't include MA, Medicare Advantage, in that goal because really in many, many ways, Medicare Advantage is already a value-based care arrangement, right? So this is a way for CMS to move all of original Medicare under some form of accountable care, some form of value-based care. Certainly managed care is counted under that. And I'm sure many of you know, we have now passed the threshold of more than 50% of all Medicare beneficiaries are covered by Part C, by an MA plan at this point. So we've got to be ready for this in nursing home world. And that's really what this is about. Nursing homes are going to have to be ready to meet future ONC requirements around their data, around sharing their data. These are requirements that we don't even fully understand yet. There will be requirements yet to come for nursing homes on reporting, mandated information, and this will come through contractual relationships that they're going to have with partners going forward. Who are partners? Partners could be an ACO. Partners could be a value-based care arrangement that is in your area. A partner could be a hospital that is in their own ACO, and your nursing facility may not be in the ACO, but because you want to receive referrals from that hospital that is in an ACO, that hospital is going to be, as part of their arrangement under an ACO, they're going to be under data sharing requirements themselves. And this is really the essence of this whole effort. And that hospital, in order to continue wanting to refer patients to nursing facilities or your nursing facility, They're going to want you, your nursing facility or chain, to be able to be interoperable with them, or at very minimum, be able to receive data electronically on patients for them at their level. And that's really the challenge here. So kind of the bottom line here is really that third bullet, to work with these ACOs. And we don't even know what other acronyms CMS is going to come up with in the future, right? Other kinds of value-based care arrangements. To work with ACOs, to work with MCOs or other of these entities, nursing homes are going to be required to bi-directionally exchange quality, performance, and financial data digitally. And that's part of that interoperability definition there, that bi-directional exchange back and forth, where you're receiving data from the hospital or other referring partner, and they can receive data from you electronically, ingest it, and use it. That's our new world, and that's going to be a huge, maybe one of the biggest parts of working with these value-based care arrangements. And we've used 2030, CMS's goal, to have all this under these arrangements by 2030. But really, that transition is going to take place from now until 2030. It's already kind of happening now with early adopters, with those of you in different arrangements now that are sharing information with your referring partners or being asked to share data electronically with your referring partners. Next slide. Okay, so how are we going to kind of deal with this from this work group? What we have envisioned is creating a survival guide for nursing facilities, and we're calling it Long-Term Vision, a SNF Survival Guide to 2030, where our very mighty group is creating a tool that is going to outline where nursing homes should be in terms of their IT capabilities at key milestones over the next 7 years. I mean, because in other words, how do you figure it out? If you're a nursing facility, you're like, okay, I'm hearing this goal, and I know we're not quite there because we're not really sharing data electronically, but we sure would like to. How do we know how to get there? You know, CMS is not putting out a roadmap to this. They're just not. And how do I know what my facility needs? Well, that's what this survival guide is all about. We are really kind of spelling it out. We are going to be directing through our guide. We'll be directing leaders to tools, to resources that can help meet your needs. And kind of a byproduct of all this is that our guide, because of its kind of step up arrangement, the way we're creating it, it will help us make a clear case to CMS, the ONC, and especially Congress for additional funding and resources that we're going to need to promote nursing home HIT adoption and advancement. Remember, those other sectors got $35 billion, and we haven't had any dollars infused into our sector. So we'd like our advocacy to be a byproduct of this. Next slide. So a little more detail here. As you know, we've not had access to the monies. And as I've been trying to make the case that adoption of HIT in nursing homes by 2030 is going to be an imperative to dealing with value-based care partners. I mean, it's just a clear case that in order to receive referrals, nursing homes are really going to have to be able to exchange data to quickly receive the patient care record, that kind of information from the referring partner. Next slide. So what are some examples of what I'm talking about? What could actually be in this guide? To give you a little more concrete piece here, I know this might be really, really hard to read, but what this is meant to illustrate to you is that our group, especially in partnership with another group called the LTPAC HIT Collaborative, we've been trying to outline, to note through all these little sticky notes you see here on this tool, which we call a mural, but we're trying to outline requirements that are known now and requirements that we think will be part of our world in before 2030. And that's what a lot of these sticky notes on the slide here kind of represent. Some requirements we know about now are, an example includes e-prescribing, electronic prescribing of controlled substances. That is a requirement on the horizon. I think it's 2025. That will be a reality in our world here pretty quickly. kind of something that people are nursing homes and others are adopting now, but is also in the near future, is remote patient monitoring. If your organization is involved in that, then you are a little further down the road in terms of your HIT maturity, and that is excellent. But as we get closer to 2030, I think many more organizations are going to be involved in something called remote monitoring because Medicare is paying for it. And that is certainly something that is very attractive. Electronic prior authorization with respect to your MA payers. That is on the near term horizon as well. And then, of course, that I keep hitting, and I'll hit it again, electronic exchange of patient data with your referring partners. So it's been a little difficult for us to create this chart because, especially in our nursing home world, we are really used to CMS coming out with a requirement and a due date, and then we have to meet that requirement, right? That's really what has driven our world for many years. HIT requirements can kind of sneak up on us a little bit in nursing home world. They come by being kind of implied, and that's really what's happening with this move to the value-based care arrangements. As your organization is more involved with an ACO or more involved with a value-based care arrangement, you're not going to see a requirement come, or I don't think you will see a requirement come directly from CMS saying, okay, nursing homes, you have got to have an electronic health record. And then by this year, you've got to have an electronic health record that can exchange data back and forth with referral partners. I don't think we're quite going to see that. It's going to come by implication. It's going to come by CMS setting up this goal and then moving all of us towards that goal. But nursing homes are going to have to, in order to be ready for that goal, it's implied that they're going to have be mature enough in terms of their HIT in order to be able to exchange data. So if you're expecting a requirement to come from CMS that we're going to slap on this chart, it may not come quite that way. And that's another reason why we need to get out there now with our readiness guide. We need to inform the sector, and there's many partners working on that. And we need to do our part as well and really make sure nursing homes are ready, because this is a world, the IT world is not something they're always as familiar with. It's harder, the vocabulary is different. And it's going to be very important to keep up. And we really think that's where our readiness guide can play a huge role. Next slide. We do have a timeline for getting this guide together. There you see on the slide some of our key milestones. We are looking to get the guide tested down the road. And so if you're interested in that, if you are a nursing home chain and willing to help us test it, we are looking for those partners as well. And as Sumari said, we of course always looking for others to join our work group, and welcome that as well. Next slide. I mentioned some of the partners. I mentioned specifically the LTPAC HIT collaborative. And if you do get a hold of these slides, I've got links to some of these partners in the slides. They've been invaluable to help our work group. In fact, they've largely put together that mural, the sticky note slide that you just saw. We have quite a few partners with the HIT vendors, and of course, other trade associations in addition to Advion. HIMSS has been very helpful. HIMSS is a co-chair to this work group with me, as well as American Healthcare Association, and I know they're on the line today. Leading Age is a partner, and I'm probably missing some other associations. I don't mean to, but they've been very helpful in trying to advance this guide. Next slide. This slide is really for those, this is a little more for those of you that are really keeping up with this really close. And this is also for everyone, though. This will kind of give you a feel for what I mean, that some of these requirements are going to kind of sneak up on us. Sure, many of you, I think all of you, probably know about the Impact Act. And why am I really connecting the Impact Act with this work? Well, you may recall that the Impact Act required that data that is assessed off the MDS be made standardized so that it could be electronically exchanged with other providers and with referral partners. So the Impact Act really set important groundwork for electronic exchange of patient data that we're still working on. And then these other laws, I mentioned the HITECH Act that put all the money out there that we didn't get a part of, MACRA, the Cures Act, and then a couple of proposed rules coming out. These all are putting different requirements into motion that really govern all of the Medicare provider world. And that's really what I mean by some of these requirements are going to be implied. Some of them are going to be on partners that we are exchanging data that we want to work with. And if we want to keep exchanging data with those partners, then we are going to need to keep up and be ready. So I think, Samari, that is it. We could move to the next slide. I know we've got a lot of comments in the chat. Should we go to Q&A, or are there other comments maybe that I missed that others want to add on?
Thank you so much, Cynthia, for taking us through the guide. I just want to make sure anyone else part of the HIT committee, if you wanted to add on to what Cynthia's shared, please let us know. If you can raise your hand or chat in, we can unmute you. And in the meantime, I know there were some questions. I think Alice, you had posed a question to the group.
I just thank you, Cynthia, that you explained it so beautifully, and I really hope people who are unfamiliar with some of this work will really feel comfortable jumping in and asking questions, because I know I personally have to hear it over and over so that I understand. Clarice Grotes is chatting in about the some of the work that Passio does, and I don't know, Cynthia, if you if you want to speak to that at all, because I know you talked about HIMSS and you talked about LTPAC, and we do want to try to integrate all the groups that are working on this. So
absolutely, I'm so glad that Passio was mentioned there. We are very integrated with Passio, especially many of the organizations represented on the work group. I know my organization is very active on Passio, especially some of the use cases around rehab therapy and trying to establish the data standards with data elements related to therapy, especially in the nursing home setting. So yeah, we are very integrated with Passio, and a lot of cross talk goes on, especially through Advion and the LTPAC HIT collaborative.
Thank you. And I had the questions I had put in were related to, again, how complicated this is. And if you are running a nursing home, and some of you on this call are running a nursing home, you're a licensed nursing home administrator, a director of nurses, or you are part of a professional association of those folks, we would love to hear from you, like how much of this sounds new to you and how much of it were you already aware of? I think, this is really the big question that the committees have been talking about. And this is one of the reasons why we think this is an important area, but we'd love to hear from you. You dialed into the call today, so we know you have an interest in this, but just let us know if you want to come off mute, and we'd love to hear people's input on, like, how new is this information today, or how much did you already know about it?
While we're waiting for that, Alice, and people, please interrupt. I just noticed in the chat a question: Are we including NACOS, AHA, and AMDA? For sure, AMDA. AMDA is on one of the work groups. I forget which, and they're also a part, just like Advion, of the LTPAC HIT collaborative. AHA is a partner we will be talking to at some point, as well as the ACOs. We've been trying to do some early interaction with at least one MA plan, trying to bring in their point of view about, hey, just right now under managed care, when you're working with a nursing facility, what kind of data standards are you requiring of that nursing facility partner? We want to get some more granularity on that. So we're talking to at least one of the really big MA plans about that. But we also will talk to the Association of ACOs as well. Certainly when it comes to when we get the guide completed and wanting to publicize and get that guide, because it'll be free, you know, publicly available, all of that. We'll want to get that guide out there far and wide. Those are some really good ads.
Thank you.
And I too would be interested if there's some nursing facilities on the line. You know, how does this hit you? Is it too foundational? Is it too aspirational? Or, you know, any reality you could bring?
You know, I'd like to share a little bit, and some of the information I have is dated, but I can remember several years back when ACOs were first formed and they were partnering with nursing homes, right? Nursing homes were so far behind because they didn't have any of the incentive monies to purchase an EHR. And so they were still in paper files, and all of the nightmare that it came along with to report underneath the ACOs, and the ACOs trying to get their information and submit it. It was just an absolute nightmare. But more recently with nursing homes adapting to EHRs, and then the EHRs still lagging, you know, they still don't have the functionality to connect and to share information seamlessly, and all of the frustrations that go along with that. I mean, I think they've come a long way. They've got, as far as I know, I mean, there's 2 leading EHRs, that's Point Click Care and Matrix, but you still have your hospital levers. You still have your overarching EHRs that aren't connecting seamlessly still. So it does, it always comes down to the money, which is frustrating.
It is frustrating. And I'll kind of go out on a limb a little bit here, but you know, I am a lobbyist by training, and I'm advocating for more money into our sector to fund EHR development. That is one of the big things I work on at Avion. But it is a reality. Congress is hurting for money. I mean, that's kind of what's going on right now. And what if that money never comes? This capability will be required of this sector. And maybe not, like I said, maybe not out and out required in an actual regulation, but it might come through how you want to work with others. And that might be a reality. So that's another reason for the readiness guide, to help people kind of now get there. One of the incredible resources that we have in our work group, and he is a guy by the name of Dr. Greg Alexander. He was part of the NASM report. He helped write the recommendation for HIT. He is a scholar on HIT maturity in nursing homes. And so he's been studying this and writing about this and actually surveying the HIT abilities in nursing facilities for many years now. And we have him as a part of our group. I'm a co-chair of a work group, and he's a co-chair of the overall HIT group. And so we have the benefit of his knowledge, his resources. And we've really come to learn that nursing homes are really all over the map. I mean, we still have facilities on paper. And so that's just another good reason why we need this readiness guide, but also why we need grounding and need input and comment from actual nursing home folks. Because this is a hard area, and we get it. You don't always know the vocabulary. We don't always know the vocabulary, but we do need to share and speak up. Because this will be a big reality for our sector. And those, as you know, those years go by fast. It'll be 2030 before we know it.
Thank you. That's great. Brian, I'm not sure if you still have your hand up or that's from before, but if you have your hand up, please go ahead and let us know if you have a question or a point.
Thank you. And thank you for the comment before about partners that would be a table. I just want to echo on that last conversation. You know, having worked in a health system with an accountable care organization, with a network of great skilled nursing facilities, most certainly the gap between our health system's EHR system, which was Epic, to interact with the variety of electronic records that exist at skilled nursing facilities. That connection does not exist. So it made me wonder if there's a a call, and maybe it's on this committee or another committee, to bring some of those major vendors to table so that they begin to think about these connections that don't exist between systems.
Brian,
Cynthia,
did
do you want to take that? I know you
Well,
guys.
I'm not sure I understand the question or the comment. You said you're talking about systems like Epic that serve hospital
Right.
or the non
Right.
LTPAC?
Thank you, Cynthia. To clarify, I think we have standing IT systems. We have several like point click care that are used by skilled nursing facilities and other vendors. Point click care is probably one of the top ones, but there are other vendors out there as well. And then on the health system side, and the ACOs would interact with these EHRs that health systems are using. So you have Cerner and you have Epic, right? The problem is there's no communication link between the two. And right, so I can select items. I can give them access via, for example, if I'm using Epic, I'm a health system, or an ACO has access to the record. I can use a portal, and the nursing home can look into the medical record at the health system. But as far as exchanging data in an IT system, that doesn't exist.
Right.
And so my question is, should we bring
Right.
the IT experts to
Gotcha.
table as this is thought about?
Gotcha. Okay. I think there's got to be cooperation on all fronts. Nursing facility needs to want that data and have that those capabilities turned on and willing to ingest the data, and it's got to be worth their while. They've got to, they don't want to just ingest data. They have to have incorporated into their work plans, and they can ask their EHR vendor, whether it's the one you mentioned, Point Click Care or Matrix Care, Experience.Care, WellSky, NetSmart. There's so many out there. I'm probably missing a bunch of them. They can explicitly ask their EHR vendor, I need to connect with this ACO. How can you make that happen? And EHR company will probably say, yeah, we can make it happen right here. We're ready to turn it on. They seek that kind of connection. They're looking to make that happen because that's what they're in the business of doing. But all parties have to want that to happen. It can be a very circular kind of world there.
But it's a good point, and the team is working on it to some extent. So thank you for that, Brian. Maria,
Thank you.
Maria, you wanted to chime in here. Go ahead.
I sure did. Hi. So I am a part of the PASIO leadership, and I can give just a real quick thumbnail on PASIO. PASIO, the Post-Acute Care Interoperability Committee group, it was formed and it is sponsored by CMS. So the MITRE Corporation provides the technical framework and a lot of the technical chops that are required to build standards that specifically focus on long-term post-acute care. And as you'd imagine, their heart beats the loudest in skilled nursing facilities. So they have been working on physical functioning and engagement, which is a way to take all of the delicious physical therapy, occupational therapy, and speech therapy assessments that we do in our communities and make that information interoperable so that it can move from system A to system B. They are also working on speech, language, and cognition. I'm the project leader for the Advanced Directive interoperability so that we can move Advanced Directive, Advanced Care Plan, portable medical order information. And PASIO has been very, very active. They've just kicked up a new project with Dr. Holly Miller and Dr. Terry O'Malley, and they're working on defining the specific data that is needed for transition of care. And they've taken a very unique approach. They are pulling representatives from every single discipline, bar none, not just your nurses, not just your physicians, but your dietitians, your certified nursing assistants, your activities directors, all of the people who really have an impact on the life of those who reside in our skilled nursing facilities. And so that's a wonderful effort. And it is built on ground roots, people that have experience, people that really want to see a change and want their voice to be magnified. So I would encourage you to get involved with PASIO. When it comes to mention of the other EHR vendors, excuse me, I've had a bit of a cold. I will assure you that many of the long-term post-acute care vendors are in there. They are working on standards. Now, whether they deliver that functionality to the skilled nursing customers, that's something that is not only based on the vendor, but it's also based on the customer's ability to really do the workflow changes that are required in order to pull information in. You know, you can't just have your normal nurse who's in charge of admissions and doing the normal nursing tasks, excuse me again, pull that information in and then automatically know what to do. These are wonderful individuals who were trained in the delivery of medical care. They weren't trained to, you know, manage computer systems. So it is a two-way effort. There is a lot of work going on. Epic is in there, Cerner is in there, Athena, you name them all on the acute side. They're all in there setting standards. And we do have our matrix cares. We do have our point click cares. We do have our, you know, NetSmarts and some of those other vendors. So I thought I would just share some of that information in hopes that it would give you some light at the end of the tunnel and let you know there is a lot of movement afoot. I hope that was helpful, Alice.
That was great. That was a super, super good overview. Thank you, Maria. Other thoughts from people about any of this? You can tell us how you feel if you're managing a nursing home. I'm just looking around at the group. I see we have a number of people who are coalition members. Dan, Lynn, Lauren, Christine, Susan, Deanna, a lot of members and others. Any thoughts specifically, or Jane or Nancy? We want to acknowledge Jane Carmody and Nancy Wexler from the John A. Hartford Foundation are on the call, and they're great about joining many of these calls. So I don't know if you guys have thoughts about this or any of the other initiatives where the John A. Hartford Foundation is also funding work in HIT.
Alice, the only thing I'm going to say is, wow, thank you for all the work that you're doing and all the connections that you're making, because this was a great learning opportunity. My colleague Nancy is on the phone, is on the call, and she is leading the work that the foundation is doing around IT and high tech. What the foundation did do, Alice, was study a few years back that the connection between hospitals and nursing homes was not there. That information is lost and it takes a long time. I've experienced that myself in my own professional career. But I'm just going to see if Nancy has some words to share with us. But thank you, everybody. This has been enlightening.
So enlightening. It was a great description of something so complicated. This is Nancy Wexler, Jane's colleague. Thank you, Alice, for the invitation. This is just such great learning. I'll say we aren't deep in this electronic health record development work, but we, as Jane said, we've done some work in the transitions of care and what works, what hasn't been working. And right now we do have a project with University of California, San Francisco to look at the 4 M's of age-friendly care and how those get tracked and how they get tracked across settings and implemented. So obviously we know that good quality care, good data tracking is very important for payment. Everything you've said here sounds like a fantastic two-pronged plan, really the short-term and long-term plan. And we hope to keep on top of this and integrate these other efforts, as you mentioned, Alice. Thank you.
Great. So Sumeri and Isaac, your thoughts?
Well, actually, I think Jeanette, I think you chatted me saying maybe you'd want to share some things.
Yes, with all the points that Maria had said, I heard nothing with regards to the patient's voice and or the family's voice in all of that material. And if we're going to be taking care of the patient, we really need to talk to them first, and then their family members. I know when I first came into this nursing home, they had a whole list of medications that were not accurate, that I was allergic to, which wasn't accurate. And it didn't get caught initially because nobody asked me. It wasn't until I had to go out to a doctor's appointment and they showed me the copy of my medication list to take to my appointment, where I pointed out, I am not allergic to that. I'm not allergic to that. I choose not to have that type of medication, but I'm not allergic to it. So I think first and foremost, residents' voice should be there. Then they need to confirm with their family, their family members or the person that would be their support person, whether they're related and or their caregiver, their basic caregiver. I think that's a point that we really need to hold on to. And then all those other components can come into that. That's the point I wanted to make.
And I think Maria, great point. And the other work group that I mentioned towards the beginning of the presentation is more of our patient focus. And Maria could do that one a lot better than I, because she's integral in that work group. I don't know, Alice, if you want to take a minute or two, I think it would be really helpful. Maybe Maria could explain that one.
Yes, and I just wanted to respond. One of the things that I do within HL7 that is maybe more important than moving information from system to system so that your information follows you no matter where you go. I co-chair the patient empowerment work group. And as a co-chair of patient empowerment, we are populated with patients, their caregivers, patient advocacy groups, and we are loud and we are not polite when it comes to the halls of HL7 standard setting. We will get right in the middle of any particular standard setting activity, and we will let them know they have either missed the boat or they have not listened to what it is that people need when it comes to their own information and their own healthcare. And I apologize that I didn't call that out. I was trying to shine a light on work that is coming that will deliver your data, and I forgot the most important people of all. And we are well represented, and we are loud and a little bit unruly in the halls of standard setting work. So thank you for giving me that moment.
Thank you, Maria. And loud and unruly resonates with every single person on this call, I'm sure. I know we only have 12 minutes left, so I want to make sure we get to everybody. So Clarice and then Dan. Clarice, go ahead.
Hi, thanks. And I agree with Maria, and I'm one of the track leads as well with Passio. I help lead our personal functioning and engagement, IG. And so I'm an occupational therapist by trade. And I will admit, one of the big challenges we've really had and things that we've asked industry leaders to start thinking about is, what does data look like that could be communicated? Because right now we've been able to be successful with communicating data around like the CMS assessments, but a lot of that is because they're standardized questions. So they have standardized questions with standardized answers that are easy to communicate. It's those free text responses or unstandardized information that becomes much more challenging from a standards level and from a data level to communicate. So, as an occupational therapist, every place I've worked, the EMR has looked different. It's captured different information in different places. Sometimes it's free text, sometimes it's check boxes. And I think a lot of that falls as well into some of that patient collected information where it's really challenging to have that go from one place to the next, especially if the EMRs have things in different locations. And we've been exploring with different ideas around trying to categorize information using the International Classification of Function so that maybe self-care data kind of goes to the same self-care place. But again, it just starts to be really challenging and balancing that balance between having enough information to feel like you are getting information, but also not so much data that then it's overwhelming and useless, right? It's like that weird in between where you don't almost want to send every single note and every single piece of data because a practitioner doesn't have the time to look at that. But if we send too little, then we also don't have enough information as well. So it's been a really interesting challenge and things that I think we'll have to think about as providers, where we know that every single individual resident patient is very different and needs different things. But at the same time, we also have to have some level of standardization in order to try and make things to communicate as smoothly as possible. So it's a fascinating challenge, and that's something that I kind of charge everyone to think about is what does that data look like?
Great. Thank you. That was really, really well said. I want to go to Dan next, but also Cynthia Uchenna put a question in the chat. If you can take a look and see if you have some thoughts on that. But Dan, do you want to go ahead?
Thanks. Yeah, I'd like to just make observations with, I'm working with the subcommittee 7 on the HIT activities, but one of the more interesting parts of that work is trying to take the goals, preferences, and priorities of the residents into mind and trying to figure out how to take that random information, that unstructured information that a person has as far as what their priorities are, and translate that into terminology that is understandable to both the resident and the clinical staff, and can be translated into data points that can be exchanged between providers so that it's meaningful, so that the next provider can understand where to go from there with the information, as well as, you know, the unique thing of taking those ideas from their goals, preferences, priorities to the care planning process. And then another group is working on taking that information at the end as a quality measure of, after the care has been provided, you know, how much of those goals, preferences, and priorities have been met. You know, how did the person convey that in a way that can be measured to demonstrate a provider's ability to do that? And I think, you know, a unique thing where we keep in mind, in this work group has a number of residents in the work group to share their ideas, and they're looking at that information from the resident's perspective. But, you know, it isn't just the clinical care that they're getting. A lot of the concerns people have is the quality of life ideas. And the group we're working on, you know, we're identifying a lot of quality of life issues that really haven't been paid attention to on the data side, to be captured and shared, because those are things that are very important to the residents. Those folks have spoken loud and clear in our meetings, and we're trying to pay attention to that and translate that into something that can be exchanged electronically to other people in the care spectrum.
That's great. And Dan, for those of you who don't know Dan, he's a tremendous voice for plain language and making things accessible throughout all this work. So thanks for that, Dan. You continue to remind us about that, as others have done on this call. I just want to go, if we can, to Nancy Tutors, who was having Sumeri, who's having some technology issues. I don't know if we can unmute you, Nancy, and if you wanted to add anything. I know Nancy's with NADANA, with the National Association of Directors of Nurses. I see she's still on. Nancy, was there anything you wanted to add to the conversation?
Can you hear me?
Yep.
Oh, good. The only thing I was going to say, you know, back years ago, I was a director of nursing in a small community, and I think it was easier then to coordinate information sharing in the smaller communities where there's one or two nursing homes, one hospital. We didn't seem to have the issues. You get in a big metro area and there's all different types of software, and that seems to be the challenge, is you can't get into theirs, they can't get into yours. So I think that finally, whether we're being forced to do it or not, I mean, it needs to happen, because it hasn't really worked on a big scale that I have seen.
I think you would find a lot of that resonates with pretty much everybody on this call. You said it really well, Nancy. And that's part of why the committee decided to go in this direction, is exactly what you said. You know, we've known it's been an issue for a long time. We really need to come together and figure out how to get it done. Mm-hmm. One other comment, just in the chat from Lauren Mikalakis, Dr. Mikalakis up in Maine, and bringing up the issue of health information exchanges. And yes, that is an important idea. We've talked, the group has talked about it. Cynthia could say more about that too. But we do want to look at those HIEs and figure out, how we can be part of that network. And if there's resources there or ways we can share. We're going to have to come together across all of these initiatives to make this work at scale. So Cynthia, I don't know if you want to say anything more about that, or anybody from the group.
HIEs are a big part of this. We've got something called TEFCA looming as well. That is a CMS kind of public-private effort to really unite all providers in terms of that will be a highway for data exchange. Think of it as a highway. I like to use my layman metaphors to help me understand all this HIT stuff. That kind of is going to happen up here, but right now we're working really on the mechanics at nursing homes to enable them to be ready for this highway a couple of years down the road.
Great. Well, Sumeri, maybe that brings us back to you. I know we have about 5 minutes left, but looks like I think we've gotten through all the comments, and thanks for responding in the chat about the mobile hospitals. That's great.
Thank you, Alice. And thank you, Cynthia, and for everyone who contributed to today's conversation. I think it's clear that effective health information technology is needed and ultimately ties to comprehensive care for residents across transitions. This is our last webinar of the series, in which we looked more closely at the 9 action plans that we published in late July. And this certainly will not be the last time you hear about the action plans. We'll be continuing these conversations and sharing updates with you and feature webinars in our newsletters. So please keep an eye out for that on our website and newsletter. And if you have any other ideas about future webinars, please let us know at info@movingforwardcoalition.org. We can chat that in. And of course, if you have any questions or have any interest in the action plans we talked about, please do let us know at info@movingforwardcoalition.org. Just again, thank you all for joining today. Isaac, Alice, any other closing thoughts? Great.
I don't think so. Everyone. Yeah, this was an absolutely great call, and many thanks to Cynthia and the team again, and to all of you for joining. To send us some new topics that you'd like to hear about, because we do follow up with those suggestions, and we really appreciate everybody's input today. So thank you all.
Thank you all.